Um, Today is Earth Day, and this is a sobering topic to be covering with all of us in the midst of something that has impacted the entire world so tremendously. Today, I'm presenting the work of a lot of dedicated people, and um, I want to state that the VA as a whole, but especially the Office of Research and Development, led by our Chief Research and Development Officer, Dr. Rachel Ramoni, um, is really thinking about this. And when several weeks ago, when several things were being organized across VA, but also in the Office of Research and Development, Dr. Ramoni made the call that some research needed to be put on hold and efforts needed to be put towards research efforts needed to be put towards solving this global problem. She referred to researchers, the great group that you all are, as a very unique resource, like one of your neighbors who has every single tool that you could imagine. And so when operations needs a particular tool, we can reach into the research shed and there's a whole slew of options. So all of the work that I'll be talking about today is directed by the Office of Research and Development, and it's in close coordination with several VA operational partners that I'll mention. To begin with, for sure, this is an unprecedented time, and the world is full of fear and uncertainty, and there's so many who wake up every day at great risk to themselves and to their families, and go out and serve. I've heard a lot of people say that they're just doing their job in various contexts, but I disagree. This is not just doing your job. Every selfless thought is above and beyond. So first, I want to say thank you to our frontline clinicians, our caregivers, and to all of those who are serving in any capacity. Dr. Michael Matheny at the Nashville VA was so kind to let me use his photo. He and I and many others have spent early mornings and late nights at the computer working on this and other related efforts. But as you can see, he's also got a day job where he goes and treats patients. So I saw on the internet something that said we are all in the same storm, but we're not all in the same boat. This has impacted each of us in different ways, personally, professionally, financially, socially, our health, our families, our relationships, our jobs, and our lives. So thank you. To start out, research partnered with some operational partners. And the first group is the National Biosurveillance Team, or the National Surveillance Team, that is made up of several groups. The Biosurveillance, Antimicrobial Stewardship, and Infection Control group, directed by Makoto Jones, based in Salt Lake City, has done amazing things to create some data sources and to support really VA's national response. That group is part of the larger Clinical Systems Development and Evaluation group, directed by Tammy Box, and we're grateful for Dr. Joe Francis and the Reporting Analytics, Performance Improvement, and Deployment, the RAPID group as well. Now, the reason I'm starting here with this clinical operations starting point is because we are a federal agency, and it's important that there is consistency. As such, there's been a tremendous amount of work happening on the clinical operations side to ensure that we have a consistent starting point. As you know, there's so much messaging that's happening. And as a research community, it is our responsibility to consider signal and noise and how we can be part of that really important signal. In fact, all of these groups have gone above and beyond to make sure that research can have the data as early as possible. Because as Dr. Joe Francis said, the clinical operations teams are serving the front line, and he and others believe that research and the scientific discoveries that you all will make will be an important part of tackling this global pandemic. I do want to also acknowledge the Office of Public Health Surveillance and Research, led by Mark Holodny, and we've worked with several of their staff, and then the Pharmacy Benefits Management Group, specifically the VA Medication Safety Center, and Dr. Fran Cunningham, who's contributed to these efforts as well. As you can see, the Department of Veterans Affairs has made some data public, and they've done this again as part of our response as a federal agency. Here is where the latest up-to-date information is stored and shown, and this compares VA cases with other infections and hospitalizations and deaths in the community. So this is a resource that you can have, and it's a public source. Now, so the National Surveillance Team created some case definitions for COVID, and these are the definitions that all of the COVID-19 shared data resource information is based off of. They do have a couple of divisions, and so here I'm showing confirmed positive and presumptive positive, and the difference between those two is really based on some early CDC standards and then VA's standard definitions. It looks at some confirmation and some manual review that happens to get the confirmed positive cases. So the majority of the data that we see currently are all VA presumptive positive cases. Now, that being said, the National Surveillance Team considers both confirmed positive and presumptive positive to be positive COVID cases. And then the other category that we have is VA negative. And so that does mean that testing occurred, but a positive result was not returned. Well, more specifically, a negative result was returned. So this is the basis of information that we're looking for. And so all of the positive and negative cases that are classified by the National Surveillance Team is available in this VA COVID shared data resource. This undertaking has been has had the most moving parts and has been the fastest moving undertaking that we've ever done. It's a coordinated lift by many different groups, and here's just a selection of all of the folks who have been helpful. Of course, we have our operational partners, and specifically Evan Carey and Craig Chrysler from the National Surveillance Team we've worked on with this particular data source. In Vinci, the efforts for this are led by Christine Lynch, our epidemiologist. The Million Veteran Program has contributed greatly. Sumitra Muralidhar and the co-PIs, Michael Gaziano, Christopher O'Donnell, and Phil Sau. The MVP Data Core has contributed a lot, and that's led by Kelly Cho. The Veterans Aging Cohort Study, including some partnerships with the MVP Champion Group that include our Department of Energy colleagues, that is led by and coordinated by Amy Justice. The Cooperative Study Program and the CSPEAR groups, so Grant Huang, the Seattle-Denver COIN has provided resources, and those are directed by David O and Michael Ho. And there's been many, many other individual investigators and teams who have contributed. The goal of the VA COVID-19 shared data resource is to provide value as quickly and consistently as possible. Now, as researchers, we're used to defining our own study criteria, and you can. But what we wanted to do was provide a starting point that gave official VA definitions that mapped VA data so that those could be used by as many folks as could. We'll talk a little bit later. As researchers, you can make changes depending on the question that you're trying to answer. You can decide who's in and who's out. You can decide what you want to count and what not to count. That's all definitely doable as part of a normal research process. And in doing this and providing this shared data resource, we're not trying to limit what research can do, but we're trying to give at least a first pass at all of those steps so that anybody who wants to join the fight against this will have a starting place, no matter if you've got the most experienced data analyst in using CDW data or you're a brilliant analyst, physician, clinician of other type, researcher who has some ideas and wants to tackle those. Because of that, our process it really hinges on these three principles: massive amounts of collaboration, and we'll invite you all to participate in that collaboration. Second, transparency, and we'll show you how everything is documented and how we have a feedback process which goes into our continual improvement. This is moving so quickly. The definitions are moving quickly. The tests are changing, and the outcomes and the other things that people are looking for are changing very quickly. And so there'll be daily refreshes, and from day to day, the amount of information and the validity of the algorithms will continue to increase. Many of the elements here have been used in other studies. Some are created specifically for this, but what we've tried to do is really build on things that have been done and validated in other settings. For each of these, though, we're trying to validate them in the COVID setting. And so when tweaks occur, that feeds into the continual improvement, and we update the documentation so you've got transparency. We're doing a lot of that, and we're asking for help, and that goes back to the principle of collaboration. So where can we learn about the data? Where are all the details of this massive undertaking? The Million Veteran Program has been leading an effort to create a VA phenomics library. And what that is, here's the URL here. It's open to everybody inside the VA, so it uses your VA credentials. Inside the VA, you can type in this address. There's also quick links. It's one of the quick links from the Vinci Central library. Vinci Central website. You can click over to the VA Phenomics library. The underlying purpose of this is to facilitate building on each other's work, collaborative work in understanding and using electronic medical record data for research. So the Phenomics library, and again, the MVP Data Core and the Million Veteran Programs in general, have populated this with hundreds of different phenotypes that have been validated in that setting. They have graciously provided some space for us to list all of the information related to the COVID-19 shared data resource. You'll see here at the top of the screen, it looks just like Wikipedia that you may be familiar with navigating. There's a navigation pane here. There's the ability to get information, how to gain access to that. We'll go over that. And then there's a list of all the different tables as well, with descriptions and then with details for each of these pages. To start off with, how do you get access to this as a new data domain? Well, the first option is if you are working in an operational capacity. That is, if you are doing something outside of a scientific endeavor, if you are being directed by your local medical center, a regional or national group that is a clinical operations group, the access to that is through the CSDE group. That's Tammy Box that you would get in touch with. When folks come and ask us for this operationally, we pass them over to the CSDE group. We are also working closely with them to sync to make sure that data that's available for research is available for operations, and data that's available for operations is available for research. But just like normal work inside VA, CDW operations work is at a different place, and it has different procedures for access than research. What we've done is we've worked with the National Data Systems Group, the data steward for the corporate data warehouse and for other VA data, to ensure that getting access to the COVID-19 shared data resource follows the same steps as for any study amendment. And I'll briefly go over those. So if you would like to study a COVID-19 research question, the first thing that you need to ask is, do I have coverage? And that is often through a study protocol where you can figure that out. Some of the IRB approvals and some of the other access, the study protocols already allow for groups to study a COVID-19 research question. Others of us who have existing studies but don't cover a COVID-19 research question, we can go into this next group that says, okay, I have an existing protocol, but I'd like to, but it doesn't cover my COVID-19 research question. So if I have an existing protocol and I would like to amend that, I can do that. And that's the same process as always. If you want to expand the scope of your research study, you can just submit an amendment. And if you do not have a current IRB that you'd like to amend, but you want to submit a new one, that's an easy process as well. For both the categories, whether you submit an amendment or an IRB, you need to make sure that you receive a waiver of HIPAA authorization and either receive study approval or an exempt determination, depending on what your study contains. Once you have achieved this step, as always, you need to get local R&D committee review and approval for a study in the VA. Our friends in the Office of Research Protection Policy and Education remind us that some existing studies that are funded either through the VA or NIH or others, they may have additional requirements. And so it's very important that you check with your study funder if you're going to amend an existing study to make sure that you're meeting all of the requirements for that as well. Whether or not you have a study protocol that you have to go through an amendment or you create a new one, you all come to the same step, which is submitting a DART amendment asking for this new data domain. And so you could say something in the DART amendment narrative, something like I'm requesting the COVID-19 shared data resource. You would update the CDW checklist and select the domain COVID-19 shared data resource. And then for all DART amendments, usually what happens is you have to update your research request memo and have that signed by your ACOS of research. As a temporary measure for studies that are existing, that have already been approved, that already have a research request memo with an ACOS signature on it, it is still required that you speak with your ACOS and make sure that they're up to date on what you're doing, but you do not need to update a updated research request memo signed by your ACOS for an existing or amended study. As it is a new IRB, a new approval, you still do need to get your ACOS to sign that off. Again, this is just a temporary measure to try and make sure that the limitations from working from home and accessing VA don't stand in the way of us moving forward. Once you have your DART amendment reviewed and approved, the COVID-19 shared data resource will be provisioned to your study space exactly like any other data domain. One point of clarification I think is important is that the VA COVID-19 shared data resource is a data domain. It is not a study cohort. So the population of patients that meets your study criteria is your study cohort. There could be a little confusion in it, and so I'm just using this as kind of an example. But let's say that you have an existing study that's looking at veterans with heart disease. Veterans with heart disease, and there may be some rules that you've defined to narrow your inclusion and exclusion criteria. That is your study cohort. Just like any study that uses Vinci, you specify what your study cohort is, and then you specify the data domains you would like to request. So without changing my study cohort in this first example, I can request different data domains. So I just used here as an example, I want patient information, right, which has the demographics, the CDW patient domain. I want the pharmacy BCMA data domain, and I want the VA COVID-19 shared data resource data domain. What that will result in is you will get all of the data that I'll discuss for the patients in your study cohort. So if your study cohort is still patients with heart disease, you will see COVID-19 information on all of the patients in your study domain. So the heart disease patients, you'll see those ones that have COVID, that have tested negative for COVID, and that don't have any testing for COVID. Now, alternatively, if what you want to do is update your study domain, or excuse me, your study cohort, you could do something like this: update the inclusion and exclusion rules and say something like, I would like to study veterans with heart disease and all persons testing positive for COVID-19, as just an example. Obviously, the study cohort is based upon your approved research protocol. So if you want to then amend it, now what you're saying is you're not only requesting a new data domain, but you're changing your study cohort to include additional patients, perhaps. And so, again, just like all Vinci studies, just because you're asking for the COVID shared data resource as a new domain doesn't mean you'll get all of the data. That's a separate request where you define your study cohort, and you will get all the data for the population of people that are in your study cohort. Note that I used specifically the terms veterans with heart disease and then all persons testing positive. VA has currently seen, of course, VA sometimes sees non-veterans as well, but specifically with COVID, some hospitals have been seeing patients that are opened up because of VA's fourth mission to serve as an additional line of hospital and healthcare when the community is overrun. So that's something to consider as you do it, as you're defining your study cohort. Going back to the collaborative piece, we've received some an overwhelming response from members of the community that have things they want to contribute. And we've set up a way to respond specifically to questions related to the COVID-19 shared data resource. And they're all funneled through vinci@va.gov. So as you're using the data and you want to report a data quality issue, or you want to work on the data access issue, if you have a question about the COVID data, what it means, or what the documentation is referring to. If you want to contribute your own data mappings, if you want to help validate mappings or algorithms that are done, and as you're working on things, if you say, oh, it'd be really helpful if we had, X, Y, and Z data elements, it's likely that we're already working on those pieces. And so we would love to either work with you or add that to the list if that's something that we currently are not working towards. Any questions related to COVID? The VA shared COVID-19 shared data resource can be addressed through Vinci at va.gov. Okay, to talk about the shared data resource, let me just say that the way we've separated up the different data elements is that we have VA-specific data and we have community-specific data. And we'll explain why we've got those and how you could use those in your own research questions. The first set of tables are our data mappings. There are data dictionaries, and in the VA, just like in Corporate Data Warehouse where they have dimension tables, we've created a set of dimension tables that specifically curate and do the mapping for medications, labs, procedures, conditions, both related to COVID and related to outcomes or baseline conditions that might be of use. Second are a set of analytic tables, and the analytic tables can be thought of as a registry type setting where individual values at a patient level are calculated. And this might be additional information. So again, we have positive and negative cases, and adding to that, we have related hospital information, and where they were hospitalized and how long it was, and are they active as a VA patient, are they a veteran, the demographics, those types of things are all cleaned and curated at the patient level for both the positive and the negative cases. In addition to kind of dimension tables and tables that are rolled up at the patient level, these analytic tables, we have teams that are curating data. And one of the ways we're doing that right now is through natural language processing. We'll go a little bit more into this and talk about how we do it for symptoms, but the structured data that looks for symptoms are not as sensitive as you may want them to be. And so we have some natural language processing tools that we run on both the positive and the negative COVID cases that pull out things like cough and fever and additional signs and symptoms that you might want to use. The last set of tables are comparison cohorts, and these are so that you can have the same data for COVID that you have for other VA cohorts. The two cohorts that are in the process of being released are patients that have used primary care. We do that on a yearly basis, and then all patients hospitalized with respiratory infections or symptoms similar to that. And what you'll be able to do is compare the data from these cohorts to COVID cases, again, as that fits your research questions. I'll show you an example of our first fact sheet. And the goal for these, and we've got statistics for along with each of the tables as they're completed, but the fact sheets just allow you to do a quick at a glance view of the updating COVID-19 case data. Community data, I'll specifically speak about hospital referral regions and effective reproduction rate. So to switch over and show you what these things look like. This is the VA Phenomics library. And so when you link here from Vinci, you'll come right to this page. And on the side, the COVID-19 shared data resource page is visible. Here's all of the data elements that are available, the data pieces as part of the shared data resource. And in each of these areas, as you scroll through, you'll be able to see information of where it came from, all of the information on getting access to the COVID-19 shared data resource, including how to get the latest CDW checklist and a research request memo, are available here, and including that regulatory workflow diagram that I walked you through. This is the information all in the same place on how to gain access to the data. As I did mention, there are many groups. As I mentioned, Dr. Makoto Jones is part of the BASIC team. He's also a research investigator. And he, along with many others, has set aside their current research to focus just on this topic. And so we're working with the operational groups to put a paragraph or some sort of citation or acknowledgement for what to put when you're using this data. The definition of the cases and the description of the data that comes to us that's used to build the VA COVID-19 shared data resource is all described here. And what I'll do is I'll start with the VA COVID dimension tables. So as I mentioned, these are similar to the DIM tables that you can find in CDW work. And I'll specifically pull up the medications table. When you come into the page that describes this, first you'll get a description of the table, and you'll see here that this is the data mappings in the data dictionary that maps COVID-19 related baseline and treatment medications to codes in CDW. What that means is all of the defined concepts have been linked to specific local drug SIDs. And so looking at the table here, you can see that we define concept IDs and drug classes, drug names, drug SIDs. All of this is how you can link back to CDW, whether it's OMOP data or the original CDW tables. And then the columns that that links to, the concept that it links to, is stored here in the column name. So if we look at down here to the best practices, it gives you some code to use to understand and run the table, and you can look at which drug classes are covered. This right here is, I forgot about the size. There you go. The this query here, if you run this query, what you'll end up with is a list of all of the different types of drug mappings that have been done. And as you come down here, you'll see that chloroquine and hydroxychloroquine and other related medications that you might have seen in the news or that might be interest to your research questions have been mapped for you. So you're welcome to take these dimension tables that you'll be provisioned as part of your study. You can join those against your local drug tables or your OMOP drug exposure tables. And from that, you'll be able to see exactly which medications from the CDW and OMOP have been linked to which of these COVID classes of interest. I'll come back here and the same on the dimension tables, the same information is provided for procedures, conditions, labs, and then also natural language processing concepts. So we do process not only signs and symptoms, but medications and many other things that we can pull from notes, and you can join against our natural language processing tables to get to the same concepts that would allow you to map cough as a structured data element to cough as found in the notes. Quickly, I'll just show you some of these analytic tables. The patient table is the first one that's rolled up, and it's got all of these pages.
Sorry to interrupt. This may be where you want to make your screen, your text a little bit bigger. Sorry to interrupt.
Thank you. All of the tables have the same page layout, where they talk about the name of the table, the description, how it's created, and then give you a play-by-play on every single column. To keep everything straight from day to day, we've created a new primary key identifier for every patient case, and that's called the COVID ID. But for that, we keep the same information that's given to us from the operations group, where they provide the patient SID, the case definition, and the case date and time. We map that to CDW and provide that high-level roll-up of the patient ICN. And then there's several pieces of information, like the demographic data that you can get for every patient, whether a veteran or not, and other information that might be relevant to your research questions. All of this is at a patient level, and you'll see that most of the information are flags or dates, which will allow you just at a glance to see how many patients fit into X category or Y category, etc. I'll quickly go and just talk about the symptoms table as well. All of these, so the pages, the formatting is all the same. What we've also tried to do is make sure that all of the columns are the same as well. And so every one of these analytic tables has the same start, where it gives you the COVID ID, the patient ICN, and then the case, patient SID, case definition, case date, etc. The symptoms that are created from this, you can see we've got fevers, chills, myalgia, etc. And the end of the table, it tells you exactly how this was determined, whether it was a yes or a no. The first piece we do is we look at structured data, and that can come from these different areas. But then you'll also see that we've got natural language processing working as well. And so you can always see how something was computed. We're making the code available. We're showing best practices on how to use the data. And for these tables that are not just linked to something, where they have further definitions, each of them has another page that describes how they can be found and what algorithm was used to create them. So you get an overview of the algorithm, where the information came from, which tables are being used for it. You can get the code elements itself and others. All of that is here within the wiki page inside the VA phenomic library. So quickly then, I'll go to the fact sheets, and I'll show you one of the first fact sheets that were published that we're putting on the site. And what it does is it just compares the positive cases, the negative cases, and then active patients or patients that have ever had one visit. So all patients in CDW have had at least one visit, as cleaned up and curated by OMOP. And you see some interesting information here. Of course, the percentage of well, I'll just say you can look at sex across these different elements, and you can notice interesting patterns. One pattern that is interesting is that overall, looking at patients who've ever had a visit in VA, about 11% are Black or African American. But of the negative patients, it's 19.2, and of the positive patients, it's 43.1. These are meant to just give you a first glance at what the data look like and spark research questions and things that you can dive into. Similarly, for ethnicity, we've got a higher percentage of Hispanic or Latino persons, individuals, because it's veterans and others, for the positive than the negative or overall in VA. And so this first spreadsheet just looks at sex, race, ethnicity, and year of birth, and we'll have fact sheets for this and statistics for all of the tables that are being created and updated. To end, I'll just give a quick view at some of the community data elements that we have. They're on the same page. They've got documentation and links to exactly where the data came from and what the data contain. The U.S. hospital capacity estimates is something that was done by the Harvard Global Health Institute and the Harvard School of Public Health. And when you link to that page, you get the data dictionary, you get the purpose of the data and why, how the data were created. And the reason why we put this community data in the same data domain as the VA data is, for example, these hospital capacity estimates are based on hospital referral regions. And there's a map that allows you to go from an individual zip code into a hospital referral region. Inside the hospital referral regions, they have estimates of, well, they have the number of beds for hospital beds and ICU beds. And they have estimates of how full those beds are on any average time before COVID. And then they make estimates for these projections if 20% of the population, 40% of the population, or 60% of the population has an infection, what that might do for the hospital beds and the ICU beds. So this is one way that you can look at the readiness, so to speak, of a local community based on our veterans that are there and the community data that are there. You can marry those two to help with your research questions. So what I tried to do is give you an overview of the VA COVID-19 shared data resource. I wanted to provide some in-depth description of what we have and why it was created. I wanted to let you know that you can contribute and how you can do that. And then finally, how to get access to the data. Very grateful for the many folks who contributed to this work, and happy to answer all of your questions.
Thank you, Dr. DuVall. We have quite a few questions queued up. At this time, let me ask you, are you able to stay past the top of the hour? Because there are quite a few questions. We could go until half past if you have the time.
Happy to help. I can stay. And then all of these can be recorded and transcribed so that if they can't stay, they can get the transcript or the audio recording, right?
Yes, and I can send you a report of all the Q&A tomorrow or later on today, actually. So let me just jump in, and I apologize for interjecting earlier. But this person asks, can you explain again the difference between confirmed and presumptive positives Is it a distinction based on what exact test was run? Is there any classification for people in whom the clinical syndrome is consistent with COVID, i.e. bilateral pneumonia, other positive clinical course, etc.? And the negative test is presumed to be a false negative. I can repeat.
Thank you. No, that's good. I think those are all wonderful questions, and I had a wonderful discussion with our operational groups last night to discuss this. Here's the bottom line. The bottom line is we're giving you all the data that's in the medical record that we've linked and tried to bring in. And so for your research study, you can help us answer questions about false positive testing and false negative testing and all those other pieces, because you'll be able to see every single test that was done and what the results of that test were, what the course of treatment was, what other things happened. As far as these case descriptions that I'm showing on the page, it's important to understand that when we're dealing with surveillance data, there is a settling period. In the medical record, it's changing so quickly that maybe a group will have some official testing names and other descriptions in there when the test is run, and maybe other places around the country won't have that in yet. So there's a process, a settling process for sure, that that goes through, and as the data get updated and the descriptions of the labs and other things get updated, a patient may move back and forth between a presumptive positive and a confirmed positive example, and that's just a part of the settling. In terms of using this and moving forward, that is something that the research community can absolutely contribute to, and we look forward to that.
Thank you, sir. Another question. Is data for non-VA people taken care of in VA recorded in the Vinci?
Yes, thank you. So the current data trend that we are seeing is in the patient tables in CDW. That's where the demographics and other information is stored. There are types of patients, and we know that there's test patients, and we know there's other types of patients like employees. If I get my flu shot, I end up in there as well. In the same way, there's a special flag that's put in, I think it's called humanitarian, when a non-veteran that comes in as part of the community and is treated as part of the community comes into the VA. Again, this is just talking about the data trend, because I think this may be settling as well, and maybe a little bit in flux. But what we do see for patients, what we're seeing in the data is that we do have patients that are listed as humanitarian. They're not veterans, but they're in the patient record. And when we see them in that patient record, we see data for them in the medical record, just like we would a veteran who's receiving care in the VA. And as best we can tell, what that means is they are registered into the system and they are put in as an official person. Their information is input, and all clinical information is documented for those patients the same way that it is for veterans who receive care in the VA.
Thank you. For amendments requesting COVID-19 data access, is an amended research request memo still required, albeit without the ACOS signature?
The advice for that may be changing over the next several days or months. We'll see how it goes. But currently, you do not need to submit an updated research request memo with or without a signature. You just need to write what you need in your amendment narrative and submit your CDW checklist. Defining your cohort and updating your cohort is done after DART. I mean, obviously you should write that in your DART, and it should be consistent with your study protocol that you upload to DART. But the actual inclusion/exclusion criteria is handled afterwards through the usual provisioning. And you can use your Vinci correspondence site to update, to work with your Vinci data manager to provision both your study cohort and data domains that you're interested in.
Can you please clarify if there is a repository of plasma/serum from the VA COVID patients or one planned?
Thank you. I'll defer that question to somebody else. Currently, there are many clinical and/or research efforts underway that are looking specifically at specimens, and that is outside the scope of the VA COVID-19 shared data resource. But if something happens to that resource, for example, if some sort of biorepository was collected and used, and those specimens are run through other testing or other genetic testing, we would try and get that data available as a part of the data domain here as well. Other groups that we're in discussions with there are some groups that do manual chart review, case reporting. There are some groups that do that are doing clinical trials, and our goal is to make it so that there's a one-stop shop for COVID-related data. You can use the same vinci@va.gov to request new data elements as you become aware of them.
Thank you. This one is a long one, so bear with me, please. Hi, Scott. Regarding the VA confirmed or presumptive positive case definition, can you help me understand a bit more how this is defined in the VA beyond lab data? Does it use ICD codes, NLP, or text notes? My concern is that patients get a diagnostic code listed on their record if they come into VA and self-report COVID infection.
Yeah, thank you. So what I'm doing here is I'm showing on the screen, I'm going to the documentation on the wiki, and we have pasted on here the patient status classification system. This is a draft from our operational partners from the National Surveillance Team, and the way that their algorithm is being used is detailed here. They do talk about using natural language processing as well as lab data and coded data is not mentioned that I see. But this document also is going through some, let me say that the algorithms that are being used are being updated and validated and modified as more data become available. Additional classifications may be made, and so the document that we got straight from the operations group, including links to the CDC guidance and the VA memos, is available right on the wiki for you to work through.
How meaningful and feasible is it to select COVID positive and negative? In other words, everyone whose caseness was solidly ascertained. And there's a follow-up. I'll let you answer.
How difficult is it to select those? The answer to the question is, I'm sure everybody on the call can come up with their own definition. What we have found is that the operations group that is specifically dedicated to making and validating that for clinical operation purposes are doing a tremendous job. And we see very little inconsistencies, and especially after a settling period where enough data is there to make a solid decision, we're seeing some solid data. So what we feel is, in terms of consistency and as 100% as the starting place, everybody can start by building off of the clinical operations definitions. As your research questions may dive into this area, you are more than welcome to use Vinci resources to study that question. As you get approval and as you have the ability to do that, we would love for you to look for ways to, vet out false positives or false negatives at an earlier stage, if you're able to do that.
Thank you. Can you give any indication of what the expectation for false positive and negative is in these data?
We do not have that information. What we do have is, for example, if a patient came in and got a negative test, let me restate this a different way. All data that's stored in the medical record is in the shared data resource. And you can get that through mappings, and you can get it through the algorithms that we use and provide as well. And so if you are interested in looking specifically at if a test was negative before and if a test is positive now, that all that data is available for you to calculate those pieces.
This person writes, I assume you can retrieve all of the COVID-related information, i.e. test results, through normal data sources and not specifically through the COVID-19 DIM tables?
Yes, our DIM tables are just a curation. And so you would join your normal lab tables, let's say, to the COVID-19 DIM lab table. And that would allow you to pull not only COVID labs, but also other interesting related labs for flu testing and several other types of things, plus just the normal labs that you would use to test for inflammation and those things. So our goal is to provide you a starting point, a mapping place, so that you don't have to come up with your own definition from scratch. You can build off of what's available. And then modify it as needed for your research question. But yes, we have had several people create their own mappings, and some of them have contributed them to this effort so that they can be used by many others, and some have had special purpose mappings that they just did for their study.
Thank you, sir. It's now 59 minutes past the hour, so if attendees need to leave at the top of the hour, please just let me remind you to provide answers to the short survey that pops up when you leave. We do count on your answers to continue to bring you high quality and very important cyber seminars such as this one. Dr. DuVall, for elements that are using NLP, are the algorithms changing over time? Is it possible to see a change in, for example, symptom status as the algorithms learn?
Great questions. Yes, and that's why this is a complicated undertaking. There's a couple of different pieces, and I'll just hit on them at a very high level. But every day, new data comes in, new COVID positive and negative case data, just like any other CDW updates. Based on those updates, what we do is we look to see if there's any new patients who have entered, and we need to process all the data for those patients. And for patients that are already in there, we may have to update the window, so to speak, of data that we we look at. They may have come in at a different station. They may have been negative last time and they're positive the next time they're tested. So we look at new patients and we look at new windows for those patients. Additionally, every day, new inpatient data, new outpatient data, new notes are written, and all of those are updated on a daily basis. So the way that we handle all of those data updates is we keep track of what has and has not been processed, both for natural language processing and for structured data, and we reprocess or we process for the first time data that has not been processed yet. In addition, because there's continual improvement in all the processes, the natural language processing tools that we have, and even the dimension tables where we add and update data mappings might have been updated that day. So you take new patients, you take new windows for patients, you take new data that was created in the medical record, you look at updates for the structured data and the data mappings, and you look at updates for the NLP systems, and then you have this complex symphony of processing all the data to make sure you've got the latest and up to date. And we are working to get that process to a daily update for you. We'll do our best to keep the documentation up to date. That will describe exactly what's run and when it's run and what the systems that are running do.
How was the list of mapped medications generated? Was it medications being used by COVID patients? COVID plus patients, I'm sorry.
Great question. So the list of medications specifically, the ones that we targeted first, the same with the labs and medications and conditions and other things that we targeted first, were based on partnerships. The initial list came from the WHO, and the WHO was collecting and looking at specific data elements, including use of medications and use of medications off-label to treat COVID, but also safety and other potential effects that happen. So we started with the WHO, we added in CDC, we added in several clinical trials that were looking at specific types of things. And then through our partners with the National Biosurveillance Team and the Public Health Surveillance and Research Group and the Pharmacy Benefits Management Group, we added data elements that they thought were important and that they wanted to look at as well. That's how that initial list was generated, and that list is being updated through requests that come from research groups and operations groups continually.
Does the use of NLP require identifiable data, or can we still do de-identified research using the NLP?
Good question. So let me put it in a little bit of a different way. If you ask for TIU notes or other type of text notes like radiology reports and others, VA has classified that as requiring, well, as being called real SSN, which requires you to do a couple of extra forms. The natural language processing output and all of the data elements that we are making available in the COVID-19 shared data resource are at the level of scrambled SSN. So the elements, the output elements that we're making available from natural language processing are just like ICD-9 codes, so to speak, or medications or whatever the piece is that's pulled out. So you do not need real SSN access to use the CDW supplement tables that are part of the COVID-19 shared data resource. But if you would like to request the notes for, again, as part of your research question, maybe you want to do chart review, maybe you want to do natural language processing of your own or validation or something like that. If you request the TIU domain or any of those other text domains, then you would be required to meet the real SSN requirements.
Does the fact sheet, include repeat positive tests like you were mentioning earlier?
The fact sheet that I showed reported the latest classification that was made by the biosurveillance team. The biosurveillance team in their list, they do not at least the data we have currently, it does not update to show that if somebody was positive and they tested later, as the guidelines have shown, again, changing guidelines. But if somebody tests positive, and then some places are testing them and trying to get 2 negatives before they end, the data that we get is just the case data that we get is just the first one. So we get that they're positive, and then we don't get they don't get reclassified for later tests. You'll still see those later tests done, but once somebody meets the qualifications for positive, that's how they're classified, and it tells you when they are. So we used that to do patient level analysis in the fact sheet.
Thank you. Do you have a rough guess of how many MVP subjects have gotten COVID-19?
It's a good question. We have not done that analysis yet, but the Million Veteran Program, again directed by Sumitra Muralidhar, is ramping up some wonderful MVP initiatives, and I'm sure they'd love to hear your feedback and how they could use that work. Overall, the Million Veteran Program has about 850,000 people. And I think that is about 7 to 10% of active VA participants. So I would, rough guess is, if MVP participants are no different than other than other people who use the VA, then maybe it's 7 to 10% of all COVID cases may be enrolled in MVP, is my guess without looking at the data.
Thank you. This person asks, are any COVID health factors included in this shared data resource?
That is a good question. We're seeing more and more health factors. And we've used health factors in some of our algorithms, but we do not have a DIM table yet for health factors. So thank you. We'll add that to the list and discuss it with our team.
This is a question about IRB process, so you may not be able to answer it. Nevertheless, can you explain the IRB submission process to use this particular data set?
Sure. Each IRB may be different. So depending on the IRB you're using, you would go through the exact same process you would for any VA study. Many IRBs require you to just describe the types of data that you'll be accessing, for any individual study participant. And so you could use some term like, I'm using data from the medical record. The electronic medical record is what many folks use. Some IRBs ask that you be more specific than that, and so you could put that we're using diagnosis data, medication data, and lab data, whatever you need for your specific IRB. You're also welcome to say that we're using the VA COVID-19 shared data resource as part of our study, and that's the most specific that very few IRBs require.
Thank you. Aside from the current data on COVID deaths and cases, are prior day or week also being made available? on the public website?
Yeah, good question. If you've been tracking the public websites, you'll see that the initial data included inpatient versus outpatient information, and it was on a different site. And as all the operations groups have consolidated and coordinated numbers, what we currently see available on the Access to Care site is what's published by the operations groups. There are additional operations tools that are being released specifically for the field. There's a facility detail report that individual medical centers use for operations purposes, but I do not know the plans of the operations groups for making additional data public. We'll get that information and pass it on to you as soon as we hear.
Is there a recruitment mechanism for VA investigators who are funded by VACO to study COVID-19?
Great question. So there's several coordination efforts that are being done, and for any COVID-related questions outside of the VA Shared Data Resource, again, you can even use it for the Shared Data Resource, and they'll send it to us. It is ordcovid@va.gov. And you send an email to that spot. You'll get connected with the people who are doing funding, and there's been several rapid review cycles that have been done by different ORD services. And then there's a set of clinical trials that are ongoing, both VA trials and federal trials and industry trials that is also being coordinated through that channel. So ORD COVID at va.gov can help with all of those needs.
Thank you. How often are the COVID domains updated?
The domains are updated. We're working towards regular updates. Let me put it at that state. We are shooting for daily updates, and we anticipate we'll be able to get to daily updates within a short period of time.
Thank you, sir. This person writes, I'm sorry, I might have missed this. Are there going to be a separate set of ICD codes related to COVID? I know some institutions have incorporated these into their EMR.
Yes, thank you. So the VA medical record is being updated in a rapid fashion. And I think the ICD-10 code went live on April 1st. And as far as we can see, all of the Vista instances around the country have updated and are using the new coding structure.
Since the ICD-10 code looks like U07.1 became available only on April 1st, will there be any BAT coding so this code can be applied retrospectively?
It's a good question. What we are working with is what is in the medical record. And so what you'll see as you look at data for some of these patients, especially before this ICD-10 code went live, is you'll see some information in the notes. You'll see some information through medications and lab testing and other things. And then clinicians have ways of entering information that doesn't necessarily fit standard coding mechanisms. We don't have yet a dim table to map all of those different ways, but there's several ICD-10 codes that and SNOMED codes that have been used, and it is unclear whether there's going to be backdating for those codes or not, but we can keep you posted as we find that out.
I'm not sure if you addressed this earlier, but would this include data on veterans who have testing outside of VA?
Yeah, good question. So just like all VA studies, we have access to the data that we can see. And some data we have more granular than others. If a veteran was treated in the community completely, then we may not have a record of that. What the medical record has is information on people that were treated inside VA facilities or that were paid for by VA facilities, or a few other caveats, but it has to have some connection to the VA. Additionally, some of the community data we don't have yet because, let me restate that. Some of the community data that the VA paid for we don't have yet because the way we get that data is a claim is submitted to the VA. So as time goes forward, the data for each individual becomes more and more enriched. But if the information was not sent over to VA or has some other connection to VA or done in VA, then there's limited amounts of information we can get from that.
Asks, what is the total number of tests, total number of positive cases in the data set? I guess that's two questions.
So, let's see. So I'll pull back up the fact sheet, and this is as of yesterday. There were 5,584 patients that have had a positive test and 44,299 that didn't. I think there was another 3,000 or so tests that were done yesterday.
Thank you. Can the number of cases testing negative be posted on the VA website? Yeah, I know you don't have access to the VA website, but.
Yeah, that's a good thought. We can suggest that to our operations partners.
Thank you. I see in CDW A01 in the database, I'm sorry, in CDW A01, the database, CSDE_COVID-19. Will that be the operational data source mirroring or replicating the research source covered here?
Great question. Currently, the data that's available inside that is the case list and other things like the facility detail report, etc. And so the answer to the question is work with the CSDE group, and they will provide access to data and/or tools. They've got some web reports, again, internal to VA. They've got, I think it's Microsoft Business Intelligence reporting and other types of tools that allow operations groups to interact and understand and track. And we are working with them to make sure that everything that's available for researchers is also has the opportunity to be made available for operations groups as well.
Dr. DuVall, do you know if there's a way to tell if COVID is the primary cause of hospitalization?
Good question. What we're seeing on many elements, and this is reflected in the natural language processing information that's out. Just like any hospitalization, you can find out reasons for hospitalization, et cetera, through a series of data points. The data points that are helpful and often more accurate, because hindsight is 2020, are the discharge diagnoses associated with a hospitalization. Now, obviously, those do not appear until after discharge. And so other data points that can be used are there's diagnosis codes that are done as part of every transfer inside the hospital. And there's a free text admit diagnosis field that we process with natural language processing and make available. And many of the times we have COVID listed there. Obviously, though, the admit diagnosis for all things, just like you might come in and say, I'm suffering from a heart attack because of chest pain and other things, but later it's found out to be something else. You would use those same types of algorithms to determine whether somebody came in for COVID or COVID-like and it ended up testing negative. You could find all that information in the inpatient tables, and you can use our mappings and our NLP mappings to help curate your efforts in that.
Thank you. You may have answered this, but what is the ICD-10 code used for diagnosis?
Rob, do you have the ability to go up a few questions? I think it was you.
I'm sorry, I
71?
don't. I've deleted everything that I've asked you.
Okay.
We can just move on.
Thanks.
Are there any limitations or considerations for research which include fourth mission humanitarian non-veteran patients?
Can you repeat that question?
It was only half of a question, actually. Are there any limitations or considerations for research which include fourth mission humanitarian non-veteran patients? Are there any differences for data use agreements or situations we should be aware of?
Let me go back and answer that last question. It's U07.1. That is the ICD-10 code for COVID. There's also U07.2, which is suspected, and Z71.1 or Z03.8, which are COVID ruled out. There's a new testing ICD-10 for COVID that's Z11.5. Which some of these are umbrella terms. So if it was ruled out, for example, that other things besides COVID could also fit into that category. Okay, Rob, now to come to this question. This is also in flux, and we are working to provide better guidance. Currently, the people who are making that determination are three folks. The first is some regulatory body like your local IRB, your local VA IRB, or the central IRB, or the IRB of record that you're using. They may be able to determine that. Use of veterans versus also humanitarian use. The second is your local R&D committee, which will review and approve it. And then the third is the National Data Systems, the data steward. So until we have further guidance on that, where a policy is released, those are the groups that'll help us make those decisions.
Is Vinci able to provide summary statistics of elements, i.e., no patient IDs, PHI, things like that, or will getting access to that information require us going to IRB, DART, etc.? Dr. DuVall, I don't hear you.
It's very important that you have proper regulatory and other approvals to publish on something. So if you anyway, that is, I'll just leave it there. But yes, these data elements are things that we're making available. And in each of these tables, we do provide just some statistics. We haven't yet done it on a row by row, a column by column basis, but that is what we are working towards. So that's the patient one. Let me just show you the symptom one real quick. So again, this is looking at the yesterday's data, and what we have is people who have a cough, and it's broken down by the different confirmed positive, presumptive positive, and negative. So you can see how many folks had these symptoms that appeared. So we'll continue to publish statistics like this on all the data sources.
Thank you, Dr. DuVall. We are approaching 1/2 and we still are not going to be able to get to all the questions. Nevertheless, how is use of mechanical ventilation identified and what criteria are used?
Thank you. This is one of the most exciting pieces that we're working on. And currently, there are some codes that are available that describe ventilation. We use those in addition to medications that are often used for intubation. And what we're finding is, and we're in the process of validating this is one of the supplemental data tables that we're preparing to make available, is that we're finding a lot more information in the notes. And so we've got natural language processing systems that look at all notes related to cases in the hospital. And we're looking for specific ventilator settings. We're looking at mentions of intubation and extubation and reintubation. We're looking for some of the medications that may not be in the structured data. They may be still noted, documented in progress notes or other things. So it's a combination of structured and unstructured data, NLP data that's extracted, that is creating both who's on ventilator and who has been on ventilator, and then giving a best estimate for a start date and an end date for ventilation, including some other information like settings and whether they were intubated in a prone position that are currently being worked on.
I think this is probably the last one we're going to have time for. This person asks if you can access this data through Prep to Research DART for protocol planning.
That is something that's in process. And so thank you for that question. The same, we've tried to set it up so that the same requirements for all VA data can also be applied just to the COVID shared data resource. And that should, again, if not now, shortly, include access for preparatory research. And then also, Vinci does offer a feasibility service where we can provide some numbers for the data. That service may potentially be affected a little bit because that same team is the one that's building and validating this, but it's still open for business. And so if you have a question where you want to know numbers of X, Y, and Z, if that's available on the documentation page, you're welcome to pull that from there, or you can put in a feasibility request at the same place, vinci@va.gov, to request some numbers.
Well, thank you, Dr. DuVall, and thank you, Jeff Sennett, for standing by. Sir, you received many, many, many thanks for this presentation today. Do you have any closing comments you'd like to make before I go ahead and close the webinar?
Well, Rob, a logistics piece, would you just like to send me the rest of the questions and I can respond in text and we can just add that to it, or what would be the best way forward?
Well, I can send you a report after the webinar finishes of all the Q&A that happened today. And I think if maybe in a couple of days, if people don't get their questions answered, they could send an email to vinci@va.gov, or would that overwhelm your front line?
Oh, that's perfect. And what we'll do is, as well, is we'll post the question and answer piece on the same wiki site. And so that'll be available to everybody as well.
Okay, we'll be happy to work with you to make sure that happens. Once again, thank you, sir, and thank Vinci for all your hard work here.